Dear Marrowlings, welcome to this video where we are going to talk about Psychiatry INI-CET May 2024 recall questions. Of course, you might have some of these questions discussed in other subjects because some of the faculties felt that is relevant to the topics they teach. So let's talk about various important psychiatric questions and understand how do we answer these kind of questions and what's the right answer. Which of these is not an essential feature for the diagnosis of autism spectrum disorder? Of course, we know a few points here, right? Autism spectrum disorder is nothing but autism and all other syndromes which are together called as autism spectrum disorder. So the question is, which of the following are kind of not an essential feature? So let us understand what are the essential features of autism. Essential features of autism are a few things. Patients having socialization deficits, patients having repetitive behaviors, patients having restrictive behaviors. When these things are happening, we call it as autism. We call it as autism or autism spectrum disorder. Correct? What you need to know here is when you talk about socialization deficits, they can be talking about poor eye-to-eye contact or poor communication, minimal interaction with other people, playing in solo, playing alone in the corner by themselves. Such kind of things can be typically seen in these children with autism spectrum disorder. Now, we know autism spectrum disorder is nothing but a developmental disorder. What you need to understand here is about 1/3 of the children with autism spectrum disorder to about 2/3. Some studies have shown even 50 to 75% of the children can have cognitive decline, can have intellectual decline or cognitive decline, can be there comorbid in autism. It is not an important feature to diagnose autism. It is a comorbid feature is what you need to understand. Intellectual disability could be there associated in 1/3 to 2/3 of the children. So generally we know about easily 30 to 35% of the children with autism diagnosis could have some kind of an intellectual problem. So with this background and understanding, tell me the answer. Persistent deficits in social communication is an important feature which is seen. Abnormalities in socializing is important feature which is seen. Restrictive behaviors and interests are actually important behaviors which are seen. So cognitive impairment is the one which is not seen in autism spectrum disorder. So that is the feature which is not essential for diagnosis. But you should know autism spectrum disorder children quite commonly can have cognitive impairment or intellectual impairment as a comorbid problem, but it is not necessarily required for the diagnosis and it is not an essential feature for diagnosis. With this, you get to know choice D is the best answer for this question. Moving to the next question. All of the following can be treated with supportive psychotherapy, except. All of the following can be treated with supported psychotherapy, except. Now, as a student, you might say, Sir, I have no idea about supportive psychotherapy. I don't know what it means. Forget about psychiatric lens. Use common sense. What does supportive psychotherapy mean? Supportive psychotherapy basically means you're trying to support the person. Now, use common sense and tell, when do you want to support people? Obviously, now you'll get to know the answer. Persons with cognitive decline and physical symptoms, can you support people with physical problems and cognitive decline? Obviously, yes. Obviously, yes. So, supportive psychotherapy can be done in these individuals, right? Next, person who has good motivation and control over frustration. Yes, you can do supportive psychotherapy, but I'll come to it later. Patient with acute psychiatric illness along with crisis. For example, somebody who is having crisis or who's having suicidal ideas and actively suicidal or acutely psychiatrically ill, can you do some supportive work with them? Can you try to support them and help them out in the crisis? Absolutely, yes. So here also you can do supportive psychotherapy. What about patients with chronic illness? Understood, with a lot of ego dysfunctioning and those things. In any person who has severe illness, chronic illness, and those things, you, irrespective of how they are, even if they're very psychotic, you still can help them to sleep better, eat better, build a little routine, take the medications regularly, which can help them. So supportive psychotherapy can be done in. So which are the situations where you can do supportive psychotherapy? If you're looking at situations where you can do supportive psychotherapy, people who are acutely ill, you can definitely do supportive psychotherapy. You can definitely do supportive psychotherapy in people who are in crisis. You can also do supportive psychotherapy who are medically ill, who are chronically ill, and basically in anybody you can do supportive psychotherapy. What about choice B here? If you see, choice B is the one which is accept. Why? Person with good motivation and control over frustration is a person who doesn't need just supportive psychotherapy. You can go beyond. You can do much more work. You can do different kinds of psychotherapy. Like, for example, you can work on cognitive behavioral therapy, dialectical behavioral therapy. You can do insight facilitation therapy. You can work more deeper with the person. You just don't need to do supportive psychotherapy. So, in anybody who has good motivation, who is willing to work on things, who are kind of very capable of understanding things, in fact, you would not just do supportive psychotherapy, you will do more individual, intensive psychotherapy based on what is required, whether it's interpersonal psychotherapy, cognitive behavior therapy, dialectical behavior therapy, or anything. So, basically, what you should understand is supportive psychotherapy is done for people who are already so disturbed that you just need to support them currently, like the acutely ill, the people who are in crisis, who are chronically ill, people who have medical illnesses, anybody. But if they have good amount of motivation and willingness, if somebody comes and says, I want to work on myself, I want to make myself much better, you don't need to do supportive psychotherapy. You can do much more better. In those people, we try to do other forms of therapy, which is more deeper forms of therapy. That's why choice B is the best answer in this question. A good, simple, practical question which is asked, where if you apply common sense, you'll be able to answer this question. Which among the following is not part of Beck's cognitive theory on depression? Which of the following is not part of Beck's cognitive theory of depression? Now, whenever you have read about depression, you would have definitely read about Beck's cognitive triad. What is Beck's cognitive triad? Beck's cognitive triad is there, which includes few things: hopelessness, helplessness, and worthlessness. So this is called as Beck's cognitive triad. This is called as Beck's cognitive triad. 1 point. Understood? But what is asked here? As per Beck's cognitive theory, which of the following is not included is what is asked. So what do you mean by this question? Here, if you read, the choices given are cognitive distortions, automatic thoughts, dysfunctional beliefs. Now, if you listen to the videos carefully, or the psychiatric class, we would have discussed about cognitive behavior therapy. In cognitive behavior therapy, what are we talking about? We are talking about something called as CBT triangle. What is this CBT triangle including? It is speaking about cognitions, it is speaking about emotions, it is speaking about behaviors. And I would have definitely spoken to you about how they are bidirectional in nature, each one influencing the other. The cognitions influencing emotions, emotions influencing the cognitions. So it is bidirectional CBT triangle we are talking about. So people can have different levels of problems. Like, for example, you can have cognitive distortions. What are cognitive distortions? These are some kind of cognitive errors people can have. These are also examples of some kind of cognitive distortions: hopelessness, helplessness, worthlessness, could be some of the cognitive distortions people carry. Understood? What are automatic thoughts? Now, another name for automatic thoughts are ants. What is ants? Automatic negative thoughts. It happens to you and me a lot, right? I'm studying seriously for my exam. Suddenly, I'm not able to answer one question which I had read sometime back and I'm not able to recall and not able to answer. Immediately, I start blaming myself. Oh my God, I'm such a useless person. I keep forgetting. What will happen for me? Next 20-30 minutes, if you have seen, there are loops of lot of thoughts which have been running in the head, nothing related to the exam we are reading, but constantly thinking about future, past, present, all muddled up. If you really see those thoughts, lot of those inner voices which are coming in are quite automatic. It's not like I'm consciously thinking about negative thoughts, it's just coming in, and most of it, majority of it, are negative thoughts, right? So these are called as automatic negative thoughts, easily remembered as ants. And ants come in bunches, right, in groups. So a lot of ants go together and each one follows the other. Same way the automatic negative thoughts also keep following one another, one another, one another. The more depressed I am, more the chances of getting into automatic negative thoughts. So that's also another thing which happens to explain how cognitive theory of depression goes on. What about dysfunctional beliefs? Now, when I'm talking about dysfunctional beliefs, you can have a very superficial belief or a very core belief. These core beliefs are what are called as schemas. There's a word called as schema. What is schema? It's a deep rooted belief which we carry about our own self, others, and the world around us. Our own self, others, and the world around us. Getting it? So, this schema is nothing but it can be maladaptive and abnormal. That's when it becomes a dysfunctional belief. For example, by nature, while growing up, I've gone through tough times, and I believe I'm a very unlucky person. Luck never favors me. That's the core belief I'm growing up with. So in future, small things to big things which happen. Like I go to a tea stall and the tea is over and this guy says, so you have to wait for 20 minutes. The milk is over. We need to get new batch of milk. Now I feel, see, I'm unlucky. Even tea stall guys are not able to give me what I want immediately. Then I go to some a payment of electric bill and the guy says, sir, internet is down. You have to wait for 20-30 minutes. Then I feel, see, I'm so unlucky. Like that, I keep on feeding that deep rooted belief I carry. And many times we can have dysfunctional beliefs which can influence our emotions significantly. That is what is dysfunctional belief. So, cognitive distortions, automatic thoughts, and dysfunctional beliefs are seen in cognitive theory of depression. What about introjection? Please understand, we have spoken about it, right? Introjection is nothing but a defense mechanism. What is introjection? Introjection is nothing but a defense mechanism. What is introjection? It's a simple example where I can give is you're owning up things which is not actually your problem. You are taking it up on you. You're feeling more guilty or more responsible than what is necessary. Let me give a simple example. I've come to do this recording. I've come to one part of Bangalore. Now I call up one of my friends and says, "Oh, I'm here near your house. Can we catch up for the dinner?" Now my friend is coming to meet me for the dinner. Unfortunately, he meets with an accident, has major fractures. Now, am I responsible for his fractures? Not necessary. Of course, it is sheer bad luck that I invited him for the dinner and he was coming and he met with an accident, but I'm not responsible for it. But a person with depression can own it up and say, oh my God, I only am killing him. Because of me only he's having fracture. I'm only responsible for it. And I beat myself, I scold myself, and I get guilty and feel depressed. That is what is called as introjection, where you own up too many things onto your own self, which could be a defense, which could be subconsciously happening, and an unhealthy one leading to depression sometimes. So that is not part of cognitive theory. Introjection is a term which is used for a defense mechanism, is important for you to know. And that's the right answer for this question. Let's move to the next question. Moving to the next question, an interesting one. We've discussed this in video, so you could have answered it easily. WHO Mental Health Gap Action Plan. Okay, what is this WHO Mental Health Gap Action Plan? It is also called as MH Gap. What is this Mental Health Gap Action Plan? This is a project which is trying to reduce the gap. It is trying to reduce the gap. What gap are we trying to reduce? We are trying to reduce something called as treatment gap. What do you mean by treatment gap? Let's imagine in a village there are 1,000 people with mental illness. So how many people should get treatment then? All 1,000 people should get treatment. But actually, do you think all 1,000 people get treatment? No. Maybe 20% of them will go for treatment, or 30% of them will go for treatment, or 40%, depending on the village, depending on the awareness, depending on the availability of the facilities, services, and those, the treatment will happen. So rest of it, people who are sick and not getting treatment, that is where you get treatment gap. Treatment gap. Do you know how high is the treatment gap in mental illness? The treatment gap in mental illness can be as high as 75 to even 85% in some situations. Which means 75 to 85% of the people who are mental illness are not even getting treatment. Forget about getting better. If they don't get treatment, how will they even get better? So, why are they not getting treatment? One, maybe there is lack of services. There are no doctors available. There are no hospitals available for them. Or maybe lack of awareness. They don't know that this is an illness and I need to go to a doctor for this. All those things. Or there could be stigma. That could be illiteracy. That could be barriers of culture and so many other things which could be happening. So all those things lead to treatment gap. And this MH gap program is trying to reduce this treatment gap. Basically, the MH gap is trying to focus on three things: M, N, S. What is it trying to look at? M, N, S. Three things. What are the three things it is looking at? Mental illness, neurological illnesses, and of course, it is also looking at substance use problem. Now, since you visited communities, these could be very, very important problems in majority of the community, right? Mental illnesses, neurological illnesses, and substance use. So, in neurological illnesses, there are thousands of neurological problems. But one of the commonest, if you have worked in any neurology OPD, what have you seen? What's the commonest problem for which people come? Of course, headache is something they come. Other than headache, one of the things commonly people come with is epilepsy. Epilepsy. So, this MH gap tries to focus on epilepsy. In terms of mental illness, it tries to focus on what? In terms of mental illness, it tries to focus on depression, bipolar disorder, and other forms of psychosis. Other forms of psychosis, schizophrenia, and other forms of psychosis. Basically, these are mental illnesses which they are trying to cover. Of course, when they're looking at mental illness and neurological problems, they're looking at children with intellectual problems, and other developmental problems, especially autism spectrum disorder. These are aspects which are being looked at, right? So, of course, substance use, one of the major things they look at is alcohol and other illicit substances. These are the major focus of this MH gap. In this question, schizophrenia is looked at, depression is looked at, children with mental health problems are definitely looked at. So what is the one which is not covered here? OCD, obsessive compulsive disorder. You can ask me a question, sir. OCD is also quite common. Yes, please understand, they obviously need to cater everything, but major focus is on these other illnesses, and they're trying to see how can we reduce the treatment gap. That's the whole concept of MH gap, which is kind of developing strategies in reducing the treatment gap, which could be as high as 75 to 85% in mental illnesses. Rapid cycling disorder is something which you would have answered easily if you have listened to the videos. So getting into the question, it is characterized by all except more common in males is what is given. So definitely that's the answer, right? It is not true. It is more common in females. Associated with hypothyroidism, yes, yep. More than 4 episodes per year. Definitely. What is the definition of rapid cycling disorder? Rapid cycling disorder is nothing but a type of bipolar disorder wherein in one calendar year, from let's imagine Jan 2024 to December 24, the patient should have had at least 4 episodes of mood problem, 4 or more episodes of mood disorder should have happened. It can be mania, hypomania, depression, does not matter what it is, but at least 4 times they should have had problems. Then you call it as rapid cycling disorder. Then you call it as rapid cycling disorder. More than 4 episodes have to happen. It can be triggered by antidepressant therapy, true, especially when you're not giving mood stabilizers. Especially when you're not giving mood stabilizers. So, what are the other important risk factors for rapid cycling disorder? The other important risk factor is also good to know. Substance use is another important risk factor. Substance use is another important risk factor. Patients who have bipolar type 2 are more prone for rapid cycling disorder. Patients who have history of cyclothymia are more prone for rapid cycling disorder. Patients who are having hyperthymic personality are more prone for rapid cycling disorder. These are all important aspects which you should know. One more important point is, what is the drug of choice for rapid cycling disorder? What is the drug of choice for rapid cycling disorder? The drug of choice for rapid cycling disorder is divalproate. This is also an MCQ which has come earlier in exams. Please remember, divalproate is the drug of choice, or they can give even valproate as the drug of choice. Divalproate is the drug of choice for rapid cycling disorder. Divalproate is also the drug of choice for cyclothymia patients. Cyclothymia patients also, divalproate is the drug of choice which can be tested in your MCQs. Let's jump to the next question. Which of the following features is not seen in Korsakoff psychosis? Which of the following features is not seen in Korsakoff psychosis? Confabulation, peripheral neuropathy, ophthalmoplegia, amnesia. Which of the following? Let us understand, first of all, there are 2 things which we should know, right? One is called as Wernicke's encephalopathy. The other condition is called as Korsakoff's psychosis. Please remember, the characteristic features of Wernicke's encephalopathy are GOA, which is almost given by every faculty, would teach you the same thing. GOA. What does it stand for? Global Confusion, Ophthalmoplegia, and Ataxia. Correct? Wernicke's encephalopathy has these characteristic features. What are the characteristic features of Korsakoff psychosis? They would have taught you about confabulation. What is confabulation basically? Filling up gaps in memory. Filling up gaps in memory. For example, I ask you, what did you eat for the breakfast today morning? Now you've forgotten what you've eaten for the breakfast. Instead of telling something, what do you say? Sir, today morning, the climate was so good, do you know, sir? Bangalore climate was like Switzerland. What was the question? What did you eat for breakfast? I've forgotten that, so I fill up gaps in memory. Something what we do in Viva exams, right? When a professor asks question, we fill up some gaps in our memory and tell some stories. Confabulate. That is confabulation. Korsakoff psychosis patients typically will have what? Very, very important feature is amnesia. Especially, they are known to have anterograde amnesia more than retrograde amnesia. What amnesia? Anterograde amnesia is more common than retrograde amnesia. Any one of you who are clinically oriented would obviously know Wernicke's encephalopathy is a very acute kind of a condition. Korsakoff's is more characteristic chronic kind of a condition. Understood? A lot of patients who get into Korsakoff psychosis would have initially had Wernicke's encephalopathy. So, confabulation is seen in Korsakoff psychosis. Amnesia is seen in Korsakoff psychosis. Ophthalmoplegia is typically seen in Wernicke's encephalopathy. Understood? What about peripheral neuropathy? Please understand, a lot of patients with alcohol use can have peripheral neuropathy, right? It's a very common problem in chronic alcoholism. So, Wernicke's encephalopathy patients can also have peripheral neuropathy. Korsakoff psychosis patients can also have peripheral neuropathy. In fact, one of the reasons why ataxia can happen, see, ataxia could be because of alcohol and cerebellar lesions, or it can also be the peripheral neuropathy which can present with ataxia. Both can lead to ataxia kind of symptoms. So you need to understand peripheral neuropathy can happen in both Wernicke's and Korsakoff psychosis. Ophthalmoplegia is more characteristic of Wernicke's encephalopathy. So what is the best answer to put across? Answer is choice C, ophthalmoplegia, which is typically more characteristic of Wernicke's encephalopathy. An important question here, a very common repeated question which is asked in exam. The EEG shown is characteristic of N1, N2, N3, and REM. I haven't shown the exact EEG because we don't know what exact EEG would have come in the exam. But what I want to show you and make you learn is the concept here because it comes quite commonly in exam, right? EEG shown is characteristic of, I'll show you a few EEGs of REM to understand, but let's understand a few interesting points here. When you talk about EEG, right? First of all, please understand when we are in awake and alert state. When we are in awake and alert state, lot of beta waves would be going around in brain. The moment you close your eyes, and start focusing, a lot of alpha waves come in. What is alpha waves? 7 to 14 cycles per second. What is beta waves? More than 14 hertz or cycles per second is beta waves. Understood? Obviously, when you're closing your eyes, you're not just closing your eyes and focusing, you slowly get into some kind of a sleep. The moment you get into sleep, you get into N1 stage of sleep. That stage of sleep is also called as micro sleep, right? It is also called as micro sleep. This is where you can have hypnic jerks, which is again asked in exam. How do you identify N1 stage of sleep? You identify N1 stage of sleep by the appearance of theta waves. Theta waves. And how do you identify theta waves? These are waves 4 to 7 hertz or cycles per second. Then you, as you're sleeping deeper, you get into N2 stage of sleep. In N2 stage of sleep, you would have read two things can happen, right? One is the K complex, which happens. Another one is the K complex, which is seen. Other one, what happens is the burst of wave, which comes again and again, which is called as sleep spindles, which come. That's how you identify by EEG. Okay, you are in N2 stage of sleep. How do you identify further N3 stage of sleep? N3 stage of sleep is identified by the appearance of delta waves. Now, delta waves are nothing but waves which are less than 4 cycles per second. These are also called as slow waves. Slow waves. So, what is the kind of sleep? N3 sleep is also called as delta sleep or slow wave sleep. There is another term for it called as restorative sleep. It is the one which kind of restores and makes you feel energetic enough after a good night's sleep. Then, of course, you have the REM phase, which comes in sleep. In REM phase, you should remember, you can see what? You can see something called as sawtooth appearance of waves. Sawtooth appearance of waves. Let me show the characteristic pictures for you to understand here. In the characteristic picture, you could actually see what happens here. You will see sawtooth appearance of waves means the waves going up and down, up and down. These going up and down kind of waves is what is called as sawtooth appearance of waves, which will be seen. And you will also see beta activity. What kind of activity? Beta activity. The EEG will be appearing in beta activity, means more than 14 hertz, more than 14 hertz, and the waves will go up and down like this, which is what is called as sawtooth appearance of waves, which can happen in REM. The question, as per the students' recall, looked like an REM phase recall. The EOG is also something you should look at. Now, the electrooculography, what can it show? It will show some kind of eye movements, like eye movements will happen. There'll be no movement for some time, then eye movements will happen. Then there'll be no movement for some time, then again eye movements will come and go. So that eye movements typically coming and going is called as rapid eye movement sleep, right? That's what is called as rapid eye movement sleep. That's what is going to happen in these people. And if you see the chin EMG, you'll see not much of activity happening. That shows the muscles are kind of paralyzed and hypotonic in these patients. So if you see when the EEG will be showing beta activity, the EEG will be showing beta activity, the EMG will be showing minimal activity in REM, minimal activity in the REM. So minimal activity in the EMG will be characteristically seen. That is very characteristic of REM. So that's why REM based question keeps coming again and again. So don't worry too much. Just understand the basics. You'll understand this question pretty well and answer this question. Another thing is a very interesting question, which I have thought most of the times when I'm talking about cannabis, I've always mentioned about the importance of medically using cannabis and all. So if you knew that, you could have answered this question here. Cannabinoids are used in all except Dravet syndrome, tuberculosis, Lennox-Gastaut syndrome, and Rett syndrome. That's the choices they have given. So what you should understand is, even if you're not sure about cannabinoids, you should have if you thought over, in all of these conditions, one thing is common: epilepsy is common, seizures are common, and resistant seizures are very, very characteristic in these conditions, right? Resistant seizures are very, very common. So cannabinoids are one of the important treatments in patients with resistant seizures. That's one reason why you should remember here in all these three, you use cannabinoids. Rett syndrome patients can also have seizures, by the way, especially later stages of Rett syndrome, children can have seizures. But here you need to understand it is not commonly used. So cannabinoids are not commonly used in Rett syndrome, but it is actually used in other three: Dravet syndrome, tuberculosis, and Lennox-Gastaut syndrome. One interesting INI-CET question which came last year was, what is the newly licensed drug for Rett syndrome? FDA approved drug is what? Trofinetide. It is an insulin growth factor 1 modulator. It works on insulin growth factor 1 and brings about better synapse and connection. So trofinetide is a drug which is used in Rett syndrome. Cannabinoids are typically ones which you should remember are used in resistant seizures. What are the other places where cannabinoids can be tried? Please remember, patients who have nausea, patients who have vomiting. The list of medically used conditions are resistant seizures, nausea, vomiting, especially due to chemotherapy, or HIV or cancer. You can use cannabinoids to improve symptoms of nausea and vomiting by increasing appetite and reducing these symptoms. It can also be used in patients with chronic pain syndromes. It is known to be used in patients with neuromuscular spasms and movement disorders. Patients with movement disorders also, cannabinoids have been tried and used, especially in resistant cases. They do try cannabinoids for sure. Where else cannabinoids can be used? Cannabinoids have been tried and used in patients with glaucoma. Getting it? So these are some of the important scenarios where cannabinoids can be tried. With this, we have covered some of the important questions which came in psychiatry recall of INI-CET. I'm sure a lot of students who went through the videos in the Q Bank would have definitely answered almost all the questions right. Best wishes for future exam, and thank you very much for listening to this video.